Hi everyone. Sorry about today's snowstorm, but I'm hoping that I can relay information within this PowerPoint to you that will be helpful in your studying for the exam. For those of you that were able to take part in my lecture this morning for a few hours, you can skip to the part 2 where it starts with asthma. If for those of you just tuning in now and listening, I would recommend that you would print the student version of the PowerPoints, which is located in Blackboard, so you could take notes along with me. If you have any questions, feel free to email me at mbull@ccri.edu. You can take time to stop and listen to the hyperlinks that are located in the PowerPoint as I'm going. I will not be playing the videos as I'm recording, but I encourage you to pause me and then listen to the videos, and I will let you know when that is time to do that. So here's a musical introduction for you. I would like you to take some time and listen to it. It's a cute little intro. It kind of sets the mood for what we're learning about. So go ahead and pause me and click the hyperlink there and listen to it. So the objectives for our PowerPoint, our lecture today, this is straight off syllabus C. So you should be able to answer the questions here, or the objectives, or at least relate to them as I'm done talking. For the exam on Thursday, you'll have 7 questions related to the respiratory content and 1 multiple answer one. I always say you have to understand the normal physiology and anatomy of the respiratory system before you can go on and learn what's abnormal about it. Take some time, pause me, click on the hyperlink below if you feel like you need a review of the respiratory system. When you are done, come back and go ahead and progress with the PowerPoint. Some of the biggest differences between children and adults in the respiratory system are kind of illustrated in this slide right here. Biggest thing to remember is that the airway of a child is a lot smaller than the adult airway. So that means that things can get lodged in there quicker. It can also mean that when they are in respiratory distress, it doesn't take as much as it would an adult to cause problems. They have smaller nares, they have a larger tongue, and they also have more amounts of soft tissue in their airways. A newborn, just to let you know, their airway size is about 4 to 5 millimeters, while an adult airway is 18 to 20 millimeters. That's a big difference. So if you think about it, that's the diameter of a child's little finger. And then when you think about it as well, a newborn also has 20 to 50 million alveoli, where an 8-year-old has 300 million. So I want you to remember what the functional unit of an alveoli is. It's to allow gas exchange between carbon dioxide and oxygen. And so if you have a lot less of them and you have respiratory distress, it's not going to take as much to get into problems than it would if you had a lot more. Also of note, newborn and infants rely on their diaphragm and abdominal muscles for breathing, hence why you see them breathe a lot more with their bellies. It's easier to see. They have decreased mucus production, and they're obligate nose breathers. So what does that mean when I say that? It requires a lot more airway secretion of their nose in order to breathe. So if you think about it, if you try to put oxygen on a nose that's full of secretions and boogers, it's not going to go anywhere. You need to clear the nasal passages first if you're going to ventilate properly a child. So here's an infant positioning. They're really cute. They have all kinds of chubby little neck rolls, but I want you to do an experiment right now while you're listening to me. I want you to take your head and your neck and lean it forward. Put your chin on your chest. Is everyone doing it? Now I want you to try to take a deep breath in and out while you're in that position. It makes it difficult, right? So think about a baby. They don't have the head control to be able to move on their own quite yet. When they're congested and their head and their position is like that, it's going to be a lot more difficult for them to get air in. So if you see the figure on the right side of the screen, A and B there, we need to kind of open up their airway a little bit in order for them to take a deep breath in and out and allow easier effort for breathing. We can accomplish that by putting a roll behind their shoulders if they're in the hospital bed and propping it up a little bit. These are some normal respiratory rates for children. I don't need you to memorize them exactly what they are. Just remember, the younger you are, the faster you're normally going to breathe. As you get older, towards school age, teenager, you start to equalize a little bit more, and you start to become more like an adult respiratory rate. An infant shouldn't breathe more than 60 breaths per minute. You're not going to have questions on the exam that's going to say, if the respiratory rate is 64, is that abnormal? No. You're going to have questions that's going to relate to a clinical scenario where you might have other symptoms related to that, such as you have a baby breathing 54 breaths a minute and they have intercostal retractions and their SAT is 89%. You're going to have more information related to that. You should know generally what these rates are, but not memorize them word for word. Pediatric lung assessments. Differences. You should observe a child quietly. I always tell people when they go into a room is to look at how the child's reacting before you even touch them. You'll be able to see if they have any work of breathing through nasal flaring, retractions, head bobbing. You want to take a listen to them, listen to their lung sounds. It's great after you're doing your vital signs, listen to the heart rate. You're going to do the respirations. You're also going to, when you get your stethoscope on the chest, you're going to listen to the lung sounds as well. You want to hear for any adventitious breath sounds. We don't percuss in pediatrics as much. I want you to also take a moment here, pause me, and I would like you to watch this pediatric lung assessment video. When you're done, unpause me and we'll move on. Signs and symptoms associated with respiratory distress. If you are hypoxic, you have an imbalance between CO2 and O2. And so you're going to display signs of cyanosis. Children, well, sometimes if they are pretty much distressed respiratory-wise, you might see cyanosis around the lips. We call that circummolar cyanosis. And they'll have increased work of breathing. You'll see retractions. Most often, children will represent with subcostal retractions, and then the retractions will increase up if they have increasing distress. They'll be restless, apprehension, inconsolable. Their skin color becomes a little bit more ashen, poor perfusion, and they might, as it progresses, have altered levels of consciousness. This is an exaggerated picture here of a newborn, but just wanted to show you. Babies tend to be a little bit more anxious looking in the face. They'll have flared nostrils. This child is what we would typically call in the clinical setting is sucking wind here. So you can see it's very exaggerated. You would see subcostal retractions around the rib cage area. Intercostal retractions are seen within the rib cage. And very marked belly breathing respirations. This child right here is in a position what we call tripod positioning. An older child will bend themselves forward in order to get more air in. You might see someone that's having an asthma attack do this. Okay, so now that you've had time to listen to each one of these sounds, I want you to know that stridor is an inspiratory sound. It's usually when someone is taking a breath of air in and there's blockage. You can't get the air in and around it. So that's what we call an inspiratory stridor sound. It's very high pitched. Wheezing is usually associated with asthma. Sometimes you can hear it in bronchiolitis as well. Um, Usually you hear it on an expiratory phase of breathing. Almost sounds like a little bit of a whistle. Grunting. Grunting is a sound that you hear with more severe respiratory distress. I explain it is that each alveoli sac in our lungs is a functional unit. There's a little bit of end pressure to keep them open. It's what we call peak end expiratory pressure. You need a little bit of that. It's like a balloon. When you blow it up, you have a little bit of like slack in there. It doesn't collapse all the way down. It's a little stretchy. Well, that's what we call PEEP. PEEP kind of allows carbon dioxide and oxygen to smoothly like transfer constantly. If they collapse all the way down, it's harder for that to happen. And so when grunting occurs, is that if you have respiratory distress, they've collapsed all the way down, and it's our body's way of trying to create pressure to open up those alveoli sacs in order to do their job. And so you'll hear that sound, grunting. Croup is that high-pitched, seal, barky, brassy cough. That's related to the airways of a child being smaller than an adult. And so when you have that increased mucus production, it causes a lot of difficulty for them to take a deep breath in and out, and it can cause a bronchospasm and their airways smaller, so you're going to get that croupy sound. Whooping cough here is a sound associated with what we call pertussis, which is a bacterial infection. It's more dangerous for a child under 2 months of age to get pertussis. We vaccinate against that in the DTaP vaccine. It can lead to severe episodes of apnea related to the bronchospasms that whooping cough causes. And the best way to protect against that is to provide immunizations. Here are some oxygen tools that I'm sure you have all had an opportunity to see if you have gone to Hasbro by now. The aerospacer here that the MDI inhaler is connected to, kids that have an MDI inhaler should always have a spacer with it. It helps with more effective delivery of the medication that is in the inhaler. If you just use the inhaler without the spacer, it tends to lose a lot of that medication after you puff it to the ambient air. This is a pulse ox. It can read oxygen off a capillary bed on the machine. You can put it on a child's finger, a child's toe. Sometimes we wrap it around the foot of babies. This is a non-rebreather mask. So if we needed to give oxygen in larger quantities to a child, we would take and use the mask if they would tolerate it. Here's a nasal cannula. So nasal cannula rates for children usually do not exceed 2 liters per minute off the wall. Rates much higher than that on a regular nasal cannula can be like sticking your head out of a car window going down the highway at about 80 miles an hour. So if kids need more oxygen off of a cannula than 2 liters, we usually start thinking about other means of respiratory support, such as going to the mask briefly, or what I'm going to talk about in a couple more slides. Here's some other oxygenation tools. Suctioning. Bulb suctions, usually infants will go home with one from the hospital. It's our job to kind of teach the parents how to use it. You would just depress the bulb down and inward, and as you put the tip of the bulb into the child's nose and pull out. This is an ambu bag that would provide positive pressure ventilation. We have different size masks for pediatric patients. These you can see at Hasbro, they connect to the wall suction. They're called little suckers. They're great. They get the boogers out a little bit more efficiently than a bulb syringe. So I mentioned briefly before how if you start needing more flow of oxygen besides the nasal cannula, we tend to start thinking of other means of getting that oxygen in. This is what we call a high flow nasal cannula. Some of you that have already gone to Hasbro might have cared for patients that were on this. You have bigger prongs that go into the nose, and it's a machine that stands on a pole. You have an air connection and an oxygen flow meter connection, and the oxygen is connected to a blender right here, and it's humidified. So with the oxygen flow, we can put it up on a kid usually to about 8 liters or so, and we're able to titrate the oxygen. So we can give them 8 liters of flow, which is blended with air at 21%, say. So if you think about what I was talking to you about before, the alveoli, they have that kind of expiratory pressure to keep them open. We're kind of allowing that 8 liters of flow or less is allowing that alveoli sac to stay open and do its job without having all the excess need to a respiratory effort to do that. And then we can titrate the oxygen down. You never want to see a child sitting at 100% in oxygen. You want to kind of titrate your oxygen so the child would sit between like 92% and 98% of O2 sat, because you want to know how much oxygen they need to maintain their sats. And if they're sitting at 100%, then you're not going to know. So that's just a note about that. So I'm sure this is a review slide for you about respiratory acidosis. Kids typically will present in a respiratory acidotic state if they are in severe respiratory distress. We don't see metabolic acidosis usually in children unless they have a chronic condition. Acidosis, again, results in when the lungs cannot remove enough carbon dioxide. You have a mismatch between your carbon dioxide and your oxygen. Signs of respiratory acidosis that you see clinically would be hypoxia, you'd be tachypnic, restless, confused, you would have increased work of breath. Your pH in acidosis goes below 7.35. Here's another review for you. You have an inverse relationship between the pH and the POC2. Your bicarb remains normal in respiratory acidosis. So here's a question for you. I want you to test your knowledge. You are the nurse caring for a 3-month-old admitted with acute respiratory distress. The arterial blood gas results are a pH of 7.26, a CO2 of 60, a bicarb of 26. Based on the results, you realize this is A, uncompensated respiratory acidosis, B, uncompensated respiratory alkalosis, C, compensated respiratory acidosis, D, uncompensated respiratory alkalosis. You can pause me if you need to think about it for a minute. I'm going to go on. So the answer is A, uncompensated respiratory acidosis. Your pH is low and your CO2 is up. Your bicarb remains normal. So based on the information provided in the last question, the nurse will anticipate the following treatment course to include. Select all that apply. When you answer these questions, guys, you want to ask yourself yes or no when you're going through each letter. So A, increase oral intake of fluids. B, provide positive pressure ventilation. C, increase the flow of oxygen. D, decrease the flow of oxygen. Or E, correcting the underlying cause of respiratory distress. Go ahead and pause me if you need to think about this. So the answer is B, C, and E. You would provide positive pressure ventilation to allow them to blow off the CO2 and ease their respiratory efforts. You would increase flow of oxygen because they're acidotic and they're hypoxic, so you need to give them oxygen. And you want to correct the underlying cause of respiratory distress, so you would correct the problem. You would not increase oral intake of fluids because if their tachypnic and respiratory distress is contraindicated, they would wind up aspirating their fluids. So nursing care management of children in respiratory distress, main goal is to ease respiratory efforts by maintaining oxygenation. Children at home, if they are at home being managed, you want to educate parents on positioning, maybe providing cool mist, humidified air. You should promote rest and comfort. You want to suction as necessary. Repeated suctioning can lead to nasal trauma, so you just want to suction when it's clinically indicated to. You want to teach parents to take careful use of decongestants. Some of the stuff on the market contains stuff in it that can actually be not beneficial and cause rebound swelling. So just plain saline works. Hot or cold applications prevent spread of infection. Number one way of preventing spread of infection is hand washing. Managing body temperature with Tylenol and antipyretics. Hydration as well, and family support and nutrition. Usually kids, when they're sick, respiratory-wise, will not be too keen on eating a lot, but the goal is to at least maintain their hydration status. I usually tell parents if they're home trying to manage, their kids should be peeing at least one wet diaper every 8 hours, or peeing at least every 8 hours. So select the right answer. You are caring for a 3-month-old with a respiratory illness. His vital signs are heart rate of 144, respiratory rate of 62, temp 38.9 rectally, pulse ox is 89%, and room air. I want you to select your priority intervention. A, administer Tylenol as ordered. B, suction the nasal passages. C, place on 1 liter FiO2. Or D, recheck the pulse ox probe. Take a second, read it again, pick your answer, and then move on. So the answer is B, suction the nasal passages, always. You want to assess the situation. If the child's congested, you need to clear the airway first to see if that improves, and then move on. Airway is always first. So the common cold, or nasopharyngitis, is what we call it. Most infections are often offenders of viral antigens, such as rhinovirus, RSV, adenovirus, enterovirus, the flu. Kids can, on average, get 6 to 7 colds per year. Viruses lodge in the back of the throat, causing inflammation and exudate formation, causing the airway to swell a little bit. Symptoms last about a week and are self-limiting. So tonsillitis and pharyngitis. Etiology, we have several pairs of tonsil tissues in back of our throat. That is part of our lymphatic system. If you remember what the lymphatic system is responsible for, it's like the drain of the body. It's draining all of the bacteria and the junk away from our circulatory system and bringing it into the lymph tissue. The tonsils are very effective at doing this. Sometimes they become more effective at doing this and can cause a lot of swelling and infections in the back of the throat. So clinical signs and symptoms of having a sore throat and tonsillitis is that you will have pain in your throat. Enlarged tonsils, some kids have what we call kissing tonsils, meaning that the tonsils are so enlarged that they're touching each other on either side. This can lead to airway obstruction and sleep apnea. You can be a mouth breather, usually is associated with a fever sometimes, and swollen lymph glands. A strawberry tongue is what is usually associated with a strep infection, which we'll talk about in a minute. So 20% of tonsillitis might test to be positive for group A, hemolytic strep. Do not confuse this with group B strep, which is dealing with a woman's vaginal canal. Group A strep is what causes strep throat. If we suspect that, a clinician might order rapid strep test and throat cultures to rule it out. It is bacterial, so it's treated with antibiotics. If it's untreated, some kids will go on to develop complications. Usually it's related to an autoimmune process. The two that we are more severe that we most often worry about is acute glomerulonephritis, which affects the kidneys, and rheumatic fever, which would affect the heart. You will learn about both of these conditions when we talk about those systems. Mainstay of strep throat is treatment of amoxicillin for 10 to 14 days or penicillin, and it's important to instruct the family and the child to finish the course of antibiotics even if they're feeling better. Here's some pictures of like normal mouth and throat. You can see that the uvula is midline here. Tonsils are normal size on either side of the throat. Here might be a child with just normally genetically large tonsils. You can see how they're getting bigger and you have less airway space here. Here's a child that might present with a little bit of sore throat, maybe some postnasal drip. It's a little red. Here's the difference between strep throat. Strep throat usually has pus formation in the back of the throat. You might see red dots along the back of the throat. They'll have a hard time swallowing. They'll usually accompany with a fever, not feeling well. Here's tonsillitis. So tonsillitis is actually, you see exudate patches on the actual tonsils. They are filled. You can see enlarged tonsils. They're really restricting the back of the throat. This child might have a little bit of hard time breathing. They'll be in pain as well. Just another picture. Complications of tonsillitis, when you have a pocket of pus in your tonsils, sometimes it can wall off and create an abscess. I've seen some children at Hasbro being treated for this, where they might need to have it surgically drained, or they're usually emitted with IV antibiotics. They will have difficulty and pain while opening their mouth. They might drool because they're having a hard time swallowing. A hot potato voice is a very kind of high, shrieky voice. It will be accompanied with a fever and not feeling good. Here's some pictures of what it might look like. So it depresses the uvula off midline, so it's pushed to the side, and you might have some swelling on one side of the neck. So risk to an airway may constitute an emergency. So anytime you have swelling in your throat that's compressing it, you always want to think about the potential for airway compromise. Mainstay, remember, airway is number one. Secure an airway. Hydration, treat fevers appropriately. Some kids will go on and need a surgical drainage of the abscess and antibiotics. So a tonsillectomy and an adenectomy. So this is indicated for children with repeated cases of strep or tonsillitis, kids that might have sleep apnea affecting their breathing because of the size of their tonsils. We try to wait till the child's over 3 years old to reduce the incidences of blood loss and anesthesia risk. Here. Okay. So the answers are A, C, and D are not appropriate. So you don't want to offer hot liquids or warm packs to the neck It can increase vasodilation, and when you vasodilate, you're at higher risk for hemorrhaging. You could offer cold drinks, or maybe an ice pack or an ice collar around the neck. That would be fine. You don't want to allow the child to drink through a straw, because that can increase the pressure in the back of the throat and cause them to bleed. Okay, so otitis media, also known as ear infections. Children are more prone to ear infections than adults because of the placement of their eustachian tubes. They tend to be more horizontal, which doesn't facilitate well for drainage of fluids. So the actual definition of an ear infection or otitis media is an infection in the middle ear. So you can see the middle ear is located behind the eardrum. The eardrum is right here. The eardrum, if you think about it, it's like almost like a trampoline, where there's that layer that kind of allows for a little bounce, but when it gets too pressurized, it can actually rupture from pressure. Eardrums do heal on their own with antibiotics and will kind of reclose, but it can cause damage and lead to hearing loss. So again, children under 3, a little bit more vulnerable. Their eustachian tubes are shorter, wider, straighter, and positioned more horizontally. As they grow older, it becomes positioned a little bit differently. So tobacco exposure can increase a child for developing otitis media. Breastfeeding decreases the risk, studies have shown, of developing otitis media. Symptoms: babies, they'll often be pulling at their ears, uncomfortable, irritable. They might have cold symptoms and inattentive to your voice because their ears are full of fluid. So here's some signs and symptoms of, not signs and symptoms, here's images of what it would look like if you looked inside someone's ear and looked at their eardrum. This is just an FYI. It's not going to be testable material here, but it's good for you to know. So treatment. Traditionally, all acute otitis media has been treated with antibiotics. American Academy of Pediatrics has recently published guidelines discouraging the use of antibiotics as a first line. Usually we go for a wait and see approach. Will take up to 72 hours or so. It depends on each clinical scenario, of course, but sometimes they will go away on their own. Sometimes they need treatment. It all depends on the child. So complications of otitis media. Chronic ear infections can lead to hearing loss. Children, remember, learn from mimicking our sounds. If they have chronic ear infections, they're not able to hear us as well and not able to speech, so they might present with speech delays. Sometimes ear infections can lead to abscess formation. Very rarely will we see meningitis or septicemia. Sometimes children that might be immunocompromised might have those problems. We consider ear infections chronic if they develop more than 2 in a 6-month period. Ongoing assessment and antibiotics would be needed, a referral to an ENT, ear, nose, and throat specialist, and an audiology evaluation to test hearing is usually done at this point. And we also do a procedure to help alleviate ear infections. It's called the tympanostomy, which is ear tubes. You can see they're like T-tubes. They cut a hole in the eardrum and they inject one of these T-tubes in, and it helps facilitate drainage between the inner ear canal and the outer ear canal, and it restores kind of balance. So this is a treatment that we would do for a child. It's an outpatient procedure, usually minimal sedation. They go home the same day, and they have sometimes antibiotic ear drops for their ears. So usually post-op teaching when they have ear tubes placed is that they have to prevent water from getting in the ears and complete the course of antibiotics that's given to the parents, well, the child, and you want to avoid using Q-tips or placing Q-tips within the ear canal. So select the best answer here. You're providing post-op teaching to parents regarding care of their child with a recent ear tube placement. What would you not say to the parents? Place Q-tips in the ears to clean the drainage. B, purchase earplugs or use cotton to prevent water from entering the ear canal. C, continue to use eardrops as prescribed. Or D, refrain from smoking in the home. Pause me, take a minute, answer this, and then go on. The answer is A, place Q-tips in the ears to clean drainage. You do not want to poke anything into the ear. It can cause more damage than good. So we're going to move on to obstructive airway diseases here. We're moving lower into the respiratory system now. So croup, you listened to a couple sounds of it before. It's a general term used to describe a cluster of symptoms. It's kind of like an umbrella term that are characterized by a barking or brassy cough. Sometimes it can lead to bronchospasms. Here's another video of the sounds of croup right here. It's hyperlinked. Take a second, watch this, and then come back. So croup affects the larynx, the trachea, and the bronchi, so more of the upper airway. Main offender are these right here, so it can be caused by many different viruses. One of your exemplars is RSV, but know that other things can cause croup. So the scientific term for croup is called laryngotracheobronchitis. So croup and laryngotracheobronchitis mean the same thing. So it's primarily affecting children younger than 5 years of life. It's preceded usually by an upper respiratory infection and onset of a low-grade fever. This has to do with the gradual inflammation of the mucosa and the irritation, causing an irritated airway, and you have that classic inspiratory stridor, which sounds like that barky cough. So it's a virus. We manage this by managing their symptoms, increasing their fluid, easing their respiratory efforts. One of the things that's a little bit different in croup is that sometimes the symptoms respond well to an oral course of steroids such as prednisone, or we have racemic epinephrine that we can give in a nebulizer, which will help kind of ease their efforts as well. So select all that apply. You are providing discharge teaching to a family of a 2-year-old diagnosed with croup. Select all the appropriate teaching points. A, you may bring your child outside in the cold air to help with a coughing spasm. B, you can provide humidity. C, you can give your child an over-the-counter coughing suppressant. Or D, provide frequent oral fluids. Pause before you go on. Answer these. So it's A, B, and D are correct. You do not want to give your child over-the-counter coughing suppressants because they can have other ingredients in there. FDA has now encouraged that we stay away from cough suppressants. It's been linked to certain deaths, so only what the doctor will tell the parents what to give. A, I had some questions on this earlier. Bringing your child outside in the cold air, it's actually sometimes can help them. It helps break bronchospasm. Also, sometimes taking them into the bathroom and having the shower, have hot water pour in the shower while you're in the bathroom. It creates steam. It can help children with croup as well. So we're going to switch to infections of the lower airways now. So bronchiolitis, this is another umbrella term. Basically, it relates to an acute viral infection occurring primarily in the winter and early spring that affects more of the bronchioles of the airways. It can be caused by some of the same organisms that cause croup, but it just affects a different area of the respiratory system. So the main offender, your exemplar that we're talking about, is going to be respiratory syncytial virus, also known as RSV. So most children have had RSV by the time they're 3 years of age. Adults can get RSV, but we wouldn't be tested for it. It presents like a common cold. Again, children younger than 3 are more at risk for complications of this because of their smaller airways, in particular children that were born prematurely or are immunocompromised. We have a vaccine that is given to high-risk children called Synagist. FDA has strict guidelines on who receives this. It's usually infants that were born prematurely or immunocompromised. It's very expensive and it's given during RSV season. So pathology and manifestations of bronchiolitis. So if you remember, we talked about before, kind of understanding the normal versus the abnormal. This will kind of make sense to you now. So bronchiolitis affects the epithelial cells, causing the swelling and production of mucus and exudate, which will fill the airways up. So you have a smaller airway that's now going to get filled of pus and yuck. So this causes the bronchi and the bronchioles to swell, become inflamed, and lead to hyperinflation of the airway, which will eventually cause a decreased space and obstruction. Air becomes trapped in the lower airways. You might hear a child wheeze because of this, what's going on. Usually a child will begin with upper respiratory symptoms. They might have an ear infection, and then it leads to a chronic cough. It will progress in some children to lower airways, affecting air exchange. So wheezing, retractions, crackles, shortness of breath, and diminished breath sounds can occur. Sometimes children with repeated episodes of bronchiolitis may be more prone to developing asthma when they get older. So how do we diagnose? Usually in the ER, if they present, or this can be done on an outpatient basis, is what we call a viral panel, a respiratory viral panel. It's like a Q-tip that will go into the back of the throat and kind of catch that mucus and that junk, and it goes into a lab medium and it goes to be tested, and we can isolate the organism that might be causing the problem. Therapeutic management, again, it's maintaining oxygenation. It's all supportive. Drug therapy only when it's indicated. Sometimes complications of bronchiolitis can lead to pneumonia. We have done studies medically, and it's been shown that the use of bronchodilators, such as albuterol, don't necessarily make them get better quicker. So the jury has been kind of still out on that. So select the best answer. You are assessing a 6-month-old infant. Upon expiration, you hear audible snore, commonly referred to as a grunt. You understand the pathophysiological process behind a grunting sound is that of A, the bronchi are swollen and air cannot pass through easily. B, the alveoli are collapsed and the child is trying to compensate by opening them up. C, the larynx is swollen and the air is trying to pass through. Or D, the trachea is swollen and the grunt is the sound of air passing through. Pause me, think about it for a minute, and then restart. So the answer is B. Remember what I said before. The alveoli are collapsed and the child is trying to compensate by opening them up. A grunting sound or a grunting mechanism is a child trying to compensate to create their own PEEP. Part 2. Hi, welcome back. So for those of you that went to lecture this morning, this is where you're going to pick up in Part 2. Asthma. For those of you continuing to listen on, I would like you to take a moment to open up the hyperlink below. It's going to show you a little video on some kids with asthma. When you're done, continue on and go to the next slide. So we're going to switch over to asthma. Asthma is primarily an allergic respiratory problem. Here's a video that I would like you to watch. It's a very descriptive video from the Khan Academy about asthma pathophysiology. It kind of pulls it all together for you. It's kind of an important video to watch, kind of explains the cascade of the allergic response and how it leads to asthma. So take a minute and listen to this video. Come back when you're ready. So, as you just saw in the video, asthma kind of causes an allergic pathway which leads to the constriction of the bronchioles in the airways. So you can see a normal bronchial tube right here versus one that's filled with pus. You can see the restricted space there. So the video talked about histamine release. So histamine causes that bronchoconstriction, that allergy response that's released by the mast cells, which results in increasing vascular permeability. Histamine will cause swelling and edema and mucus production, and therefore will narrow the airway. There can be a genetic component related to asthma. So again, this is just showing you what the video talked about again. So it's an overview of what happens when someone comes in contact with an allergen, and how the allergen connects to the cells. And it kind of gives the message to the cell to release these IgE antibodies, which will attach to a mast cell, and that sends the message to release the histamine and other chemicals, which causes the allergic response. So asthma is the number one, or one of the leading causes of chronic disorders in children of the airways. It's complex, characterized by variable and recurring symptoms, airflow obstruction, bronchial hyperresponsiveness, and underlying inflammation of the airways. So the prevalence, morbidity, and mortality are increasing in the United States, especially among African Americans. It's the third leading cause of hospitalization in children younger than 15 years of life. Most common chronic disease of childhood, altered facial appearance. So management. Goals always are to control the asthma flares, avoidance of triggers, which we'll talk about in a minute. You want to get them functioning as normal as possible, prevent chronic symptoms, and provide optimum drug therapy. So general treatment, we want to avoid allergens. I will show you the next slide about common allergens to avoid the asthma attacks to begin with. Use of antihistamines. Common one would be Benadryl, or other ones that would block the action of the histamines. Primary treatment, sometimes the use of corticosteroids. It will decrease the inflammation of the lungs. We'll use different immunotherapies sometimes, which are given like allergy shots to decrease the response to certain allergens and triggers that children might have. That's always done in an office, and they usually get referred to an immunology expert on that. Here's some common allergens. Biggest one usually, believe it or not, are cockroaches. They emit something that causes the more severe reactions, actually. Indoor molds, pollens, animals, dust mites, viruses, and bacterial infections can cause someone that's prone to asthma to have an attack as well. Smoking is another big one. So medications used to treat asthma. So our first line of action during an attack would be a rescue inhaler or a short acting, is what we call SABAs. So albuterol is a perfect example of this. I'm sure you have learned some of this before and in pharmacology. Albuterol is a beta agonist. It kind of relaxes the muscles. It's a bronchodilator. You want to use this as a rescue. So if someone's having an acute asthma flare, you want to give them albuterol to try to immediately bronchodilate. So nursing pearls. It can cause tachypnea. It can cause, well, not tachypnea, it can cause tachycardia, and they might feel a little jittery after subsequent doses of albuterol. Long-acting beta agonist would be something that you would use to maintain and keep a child at bay to avoid overall attacks. So that would be some like your Solumetrol. We will use, usually with the long-acting inhalers, they need to rinse their mouth after they use it. Corticosteroids is something that we use for management as well. It will, like methylprednisone, it decreases the inflammation overall in the lungs because we're dealing with a hyper-responsiveness of the airway, allergic responses. So steroids will help reverse that. Nursing pearls, if it's inhaled, you need to rinse your mouth after using it. Long-term corticosteroid therapy can lead to some unwanted side effects, so usually we will treat with short bursts of steroids unless a doctor decides otherwise. So nursing care of an asthmatic, you want to give order treatments promptly and be aware of dose timing. A child out in the community that's having an asthma flare should always be in contact with their physician, but have inhalers. If they're needing them more than every 4 hours, it's time for them to get evaluated. Sometimes they can get them every 2 hours at home, but they really need to call their doctor if they start needing them more than that. If you're in the hospital, you want to increase oral intakes of fluids, monitor oxygenation. You want to withhold oral fluids if they're having a severe attack. Keep a calm environment. Monitor closely for any changes of physical and mental status. Ongoing management. Education is key in asthma. You want to educate the family on how to manage asthma symptoms, proper use of inhalers. Number one reason they come back is that they're not knowing how to take their medications properly, especially the use of a spacer and inhalers. They should know about pharmacological therapy and educating of what, allergy testing, what they need to avoid. A lot of outpatient resources are available for families through community resources. There's movies here for you to watch. The one that I really want you to focus on is how to use an inhaler here. It's a physician that goes over and shows you the proper use of an inhaler with a spacer. So it's the second one right here. Take a time, use the hyperlink, watch it, because number one reason parents do not grasp the importance of how to use the inhaler properly, and it usually will cause readmissions to the hospital. So that's a good one to watch. Watch it and come back. Again, education, key. They should know the basic dynamics of the disease, prevention of the attacks to begin with, and devices and treatments and medication. If they live in a home that family is smokers, you need to treat the family as well, give them resources on, how to quit smoking, refer them to some programs. It's key. So select the best answer here. You're preparing a care plan for a 9-year-old with an exacerbation of asthma. He plays soccer at school and he enjoys being active. part of your teaching plan should include A, avoid outside activities because it will make your asthma worse. B, consider switching to swimming instead of soccer to avoid allergens. Or C, take your albuterol inhaler 30 minutes prior to soccer practice. So it's C, take your albuterol inhaler 30 minutes prior to soccer practice. So for a child that has chronic asthma, that exercise might be a trigger for them. We always pre-treat. They usually have a healthcare plan in place in school with the nurse, and they come in and get their inhalers before gym or recess. So we're going to switch to cystic fibrosis. This is another exemplar for this content. So cystic fibrosis is a hereditary disorder. You're born with it. It's characterized by lung congestion, an infection, and malabsorption of the nutrients by the pancreas. So it is a X-linked not X-linked. It's an autosomal recessive gene that causes cystic fibrosis. So you need to have two parents that have the recessive gene in order to have a child that will express the disease. So they have a 1 in 4 chance of developing cystic fibrosis, as it's demonstrated in the picture. Underlying defect in cystic fibrosis. I'll explain it to you right here. So it's a defect on chromosome 7, which kind of is responsible for releasing or creating a protein that will help sodium chloride or salt move in and out of the cells. If the protein isn't working correctly, then the salt cannot move in and out of the cells. Normally, sodium chloride acts as a lubricant for mucus, which will kind of line the airways and something. So when that's missing, you get that thick, sticky mucus, and it's stuck outside of the cells. So typically, sometimes this might be picked up on a newborn screening. I know in the state of Connecticut, and I'm pretty sure Rhode Island too, on the newborn screening, they screen for cystic fibrosis. Sometimes prenatally, you can be tested for, a mom can be tested to see if she's a carrier, and then the partner can be as well, which would kind of give you an idea. If a newborn screening comes back positive, or we're suspecting cystic fibrosis in a child, they'll do a physical exam, obviously, and a cluster of symptoms are looked at. Sweat testing is done. Remember, the primary defect is within the sodium chloride. They'll tend to have more salty sweat, and so we can do sweat testing to analyze that, and also DNA analysis. So nothing is confirmed unless genetic testing is done. Cystic fibrosis is a multi-system disease. Primarily, it affects the lungs, and secondarily, it affects the GI system. So the lungs are the ones that are more prone to having problems. Also, because of the problem with the mucus, we tend to see digestive problems. These children will need pancreatic enzymes with food to be able to digest properly. So the lungs, again, have the primary defect. So you can see pictures here of healthy lungs versus lungs with cystic fibrosis. They get clogged up with thick mucus. Signs and symptoms in newborns you might see is a meconium ileus. You all know that meconium is the stool that forms in the intestines during when fetuses are in utero. Children sometimes will have a difficulty passing it and have an ileus of meconium. It's not always associated with cystic fibrosis, but it can be. They might be failure to grow, unable to maintain calorie growth because of the GI complications. They'll have the bulky and the greasy stools. Again, they're not absorbing their calories efficiently in their gut. which is causing a malabsorption problem, so their stools will be really smelly and greasy. They might have frequent respiratory infections. So beyond infancy, we'll see children again with chronic respiratory infections, um, salty taste to the skin. They'll be a lot thinner because of the malabsorption problems, and they'll have a deficiency in vitamins A, D, E, and K that's related to malabsorption. And you might start seeing chronic signs of hypoxia, which would be the enlargement or rounding of the fingernails, the clubbing. Here's what a clubbed fingernail will look like. You might see this in a older patient with chronic lung disease. So cystic fibroses are often accompanied by polyps in the nasal passages. Sometimes you'll wind up with cirrhosis of the liver due to inflammation of the bile ducts. That's resulting from the inflammation or the malabsorption of the gut. You'll have pancreas issues. Sometimes children with cystic fibrosis will also develop diabetes mellitus type 1. Sometimes children will have intussusception because of the GI complications, and infertility can sometimes be a result. So pneumothorax. A pneumothorax is a collection of fluid that will actually kind of collapse an area of the lung. You'll have absent breath sounds when you listen to them. Sometimes this can happen in children with cystic fibrosis because of the kind of thickness of the mucus and the clogging. Treatment. Maintain health. You want to prevent overall infections. Children tend to, with cystic fibrosis, tend to pick up all kinds of different infections that you wouldn't normally see in the average population. So you want to also reduce the amount and thickness of secretions in the lungs. So a lot of children, they'll have daily rituals of chest PT and saline inhalers to loosen up their lungs. You need to improve the airflow, so they'll have nebulizer treatments. They work really closely with respiratory therapy as well as nurses. And growth. We want to maintain growth, so adequate calories and nutrition. These kids need to have increasing protein, and every time they eat, they need to take their pancreatic enzymes, which will help digest their food and give them the nutrients that they need. They also need supplementation of vitamins A, D, E, and K. So supplements are taken with meals. Antibiotics, when they present with infections, you want to, the doctors will usually try to isolate the organism causing it. Since these kids get so many lung infections, we want to prevent the overuse of broad spectrum antibiotics to decrease resistance. Mucus thinning drugs like hypertonic saline is something that we will use, and also chronically, like we might use the Singulair sometimes. Bronchodilators are often used in patients with cystic fibrosis. So here's some images of chest PT. An older child will probably have a prescription and going home with a chest vest, which will kind of provide chest PT a couple times a day for them. They'll need that. Again, oral enzymes and better nutrition to aid in digestion. Higher calorie supplements. Some children will be prone to constipation, so having a good bowel regime if needed. Lung transplantation is usually done with at the last resort. We used to have children with cystic fibrosis used to not live as long as what they're living now. I'd like you to click onto the lower link here. I think this isn't hyperlinked, so you might need to copy and paste it into your Google bar and watch this video. It's a very compelling video of a woman that has lived her life with cystic fibrosis. After that is done, I want you to come back. So long-term prognosis of cystic fibrosis, it depends on the severity of disease and organ systems involved. Back in 1959, a child wouldn't live past 6 months. Back in 2006, the average life expectancy was 37. I now hear of people living well into their 40s with cystic fibrosis. So select the best answer. You are providing preconception education to a young couple. The mother shares that she carries the cystic fibrosis gene and is worried that her baby may have the disease. Your best answer to her is A, you might want to consider adoption. B, in order to have a baby with cystic fibrosis, your partner will also have to carry the gene. C, you might want to consider further genetic testing. Or D, cystic fibrosis is a disease that is curable. Answer is B. It's an autosomal recessive gene, so both partners have to carry the gene. So the next couple slides kind of deals with the nursing process. Obviously, we're not able to work in groups here, but I'm going to go over some main points that you should be aware of. Okay, so pause me, think of some important tips here, and then turn me back on. Okay, so main points here. This is a 15-year-old. You need to try to teach him avoidance of allergy triggers. Remember, education is key. You want to get him compliant with his treatment regimen, so maybe hooking him up with other children that have asthma, working out a plan that works for him that's individualized is going to be more comprehensible. Getting his parents involved in the treatment plan. He's a basketball player, teaching him how to use his inhalers before he goes for his games. Those are all great points. Teaching him warning signs of worsening asthma attacks, when he's starting to use his inhaler more, when he needs to call the doctor. Those are all key points. Here's our next slide. You're caring for a 1-month-old in the emergency department. She is presenting with a history of nasal congestion, non-productive cough, and expiratory wheezing. She has a rectal temperature of 38.9. Her SATs are 88% in room air. Past medical history is significant for being born at 34 weeks gestation and having an older brother at home that is sick with a cold. What is her likely diagnosis? And write a care plan that will entail her hospital stay. Pause me, put some notes down on a piece of paper that you think are pertinent, and then turn me back on. All right, so we're back on. So, what do you think? It's bronchiolitis and probably RSV related. This is a preemie, so we know that she's going to have a kind of a weaker immune system to fight this off. So primarily, we want to promote oxygenation and ease respiratory efforts. So we need to get her admitted to the hospital, put her on oxygen, suction her nasal passages first, keep her on a monitor, increase fluid intake by IV, manage her fever, and let it run its course. She will not be able to go home until she's off oxygen and able to tolerate all nutrition by mouth. So teaching plans would be avoidance of sick contacts. You want to teach the parents signs and symptoms of worsening distress, such as increasing nasal flaring, color changes, not being able to tolerate bottles, not peeing enough at home, at least they're not having a wet diaper every 8 hours. Those are all points that you would hit on. So let's guess it. You're the school nurse. You have a 5-year-old coming in gasping for air, has perioral cyanosis, anxious, pale, heart rate of 130, lung sounds are very tight and wheezy. Past medical history includes allergens to peanuts, milk, and eggs. What do you do? And write a nursing care plan. Pause me, put some points down, and turn me back on. All right, if you guessed that he's in anaphylactic shock, you are right. So we need to give him his EpiPen. At this point, this is anaphylaxis. We need to reverse the process. You want to give EpiPen and call 911 if you are in the community. You can give 2 rounds of epinephrine straight into the thigh, 10 minutes apart if they are not relieved of symptoms before EMS gets there. Once this child's stabilized, and if you are caring for him in the hospital after his EpiPen, usually we'll have a dose of Benadryl. They'll be monitored overnight and sent home, maybe with a referral to allergy testing if we don't know what caused it. As a school nurse, you always have an emergency EpiPen in your office, even if children don't have a known allergy, because they might present for the first time in your office with an allergy that's life-threatening. So nursing care plans, if you're the school nurse caring for this child going forward, is to identify the allergen, communicating with teachers and lunchroom staff about the avoidance and cross-contamination of allergens, teaching the child about their allergies and signs and symptoms of when to report to the nurse, and having a health care plan in place with the family, the teachers, and the nurse. So we're going to go over some questions now. This is all from my book, Dr. Peck's Pediatric Review Simplified. After I read each question, you can pause me, think about the answer, and then move on. If you have any questions about this that I'm not explaining well enough to you here in a recording, feel free to email me. So select the best response. An 18-month-old child is being treated in the emergency room for acute laryngotracheobronchitis, also known as croup. The nurse needs to reassess the child's respiratory status after a nebulizer treatment of racemic epinephrine. What action by the nurse is most appropriate? A. Ask the mother how she feels the child's doing. B. Address the mother's guilt about smoking around the toddler. Allow the child to remain on the mother's lap for assessment, or lay the child supine on the exam table to do a thorough assessment. C. You want to allow the child to remain on the mother's lap for assessment. An 18-month-old is in that middle of that stranger danger anxiety, separation anxiety. So allowing the child to remain with the mother will keep them calmer, and you'll have a better assessment. A nurse is now caring for an 8-year-old child with an acute asthma exacerbation. Which assessment finding should the nurse immediately report to the provider? A. The child's mother confesses to the nurse that she is not very good about giving her child his corticosteroid inhaler every day. B. Physical assessment reveals diminished breath sounds bilaterally. C. The child's respiratory rate is now 26 breaths per minute. Or D. Recent blood gas analysis reveals an oxygen saturation of 95%. The answer is B. Physical assessment reveals diminished breath sounds bilaterally. That means the child is closed off. So that the provider needs to get in there. We need to get bronchodilators started right away. Remember, airway. Airway is always important. So a 7-year-old child has just returned to the post-anesthesia care unit after undergoing a tonsillectomy. The nurse observes the child swallowing frequently. What is the appropriate nursing intervention for the child? A. Apply warm compresses to his neck. B. Check the child's pulse and blood pressure. C. Encourage the child to cough up any drainage. Or D. Place the child supine with his head and neck flat. B. Check the child's pulse and blood pressure is correct. A sign that a child is swallowing frequently post-op TNA might indicate a hemorrhage. And so if you're hemorrhaging, you're going to notice changes in your vital signs. Select the best answer. A mother calls the nurse to inquire about giving her toddler an over-the-counter cold medicine. She wants to know if it's acceptable to give Tylenol or acetaminophen for fever concurrently with cold medicine. What's the best response? Ask the mother to list the ingredients in the cold medication. Tell the mother that it's safe to give both. Advise the mother not to give both medications. Recommend a call to the local pharmacy. The answer is A. You want to find out what's in the cold medicine before giving it, because sometimes Tylenol is already in a cold medicine, so you might double dose. So a nurse is giving home care instructions to a mother of a child diagnosed with strep throat. Which information is incorrect and should not be included? Replace the child's toothbrush after 72 hours. The child may return to school after 24 hours of antibiotics. It is important that the child finish all the medication as prescribed, or force the child to drink at least 24 ounces of fluid per day. The incorrect answer is forcing a child to drink at least 24 ounces of fluid per day. While increasing fluid intake is necessary, you cannot force a child to do anything. So you'd have to come up with other unique ways to try to get fluid into that child. Select all that apply. A nurse is completing a health history for a 9-month-old infant. Which of the following should the nurse identify as risk factors for otitis media? Select all that apply. A. Secondhand smoke exposure. B. Propping the bottle for feedings. C. Daycare attendance. Or D. Low socioeconomic status. They all are. All of these are associated with risk factors for otitis media. So select the best answer. A provider orders a throat culture for a 4-year-old patient in the ER. The nurse enters the room and finds the patient agitated, drooling, and sitting up leaning on her arms. What is the appropriate action of the nurse at this time? A. Notify the provider. B. Continue the procedure and notify the provider. C. Auscultate the patient's lungs. Or D. Take the child's vital signs. It's A. You should immediately notify the provider. You have a child that has an impending airway emergency at this time. Drooling is a sign of not being able to swallow. Agitation is a sign of increasing respiratory distress, and the child's in tripod positioning here. So select all that apply. Which of the following symptoms are early signs of impending airway obstruction? Tachypnea, tachycardia. C is decordate posturing, restlessness, and cyanosis. It's tachypnea, tachycardia, and restlessness. Those are all early signs of impending airway obstruction. Decoordinate posturing and cyanosis is late signs. That's beyond early. What is the most effective way to promote infection control when caring for a hospitalized patient with RSV? A. Meticulous hand washing. B. Restrict visitors. C. Contact precautions. Or D. Grouping RSV patients together. If you didn't guess A, you need to go back to nursing 1010. Just kidding. Hand washing is always the #1 way of spreading infection of everything. So select the best answer. A nurse is emergently called to the hospital playroom and finds a 2-year-old child who is cyanotic, cannot speak, and collapses in front of the nurse. What is the appropriate immediate action of the nurse? A. Begin CPR with chest compressions. B. Begin 5 cycles of back blows and chest thrust. C. Administer oxygen by mask. Or D. Call the code team. It's B. Begin 5 cycles of back blows and chest thrusts. So remember your basic principles of first aid and CPR. You witnessed this child that collapsed in front of you. So you know that he probably choked on something. It's an airway obstruction. So you want to begin back blows and chest thrusts. An adolescent comes to the school nurse's office with complaints of an asthma exacerbation and severe shortness of breath. Upon assessment, the nurse auscultates but hears no breath sounds, despite a respiratory rate of 56. What action should the nurse take? Administer the teen's albuterol inhaler immediately, administer oxygen by face mask at 10 liters, call 911, or have the teen breathe into a paper bag. You want to immediately call 911. You are out in the community. You have no breath sounds. You are on the tip of having complete respiratory failure. So you need to get 911 there. So you call them immediately, and then you can progress with bronchodilators after that. A nurse is caring for a child hospitalized with asthma. The nurse enters the room and assesses the vital signs. Pulse is 146, temperature is 97.2, respirations are 26, blood pressure is 96/24, SAT is 94%. The child is agitated, shaking, and crying. What is the appropriate initial action by the nurse? Check the medical record to note the time of the last breathing treatment. Call the provider. Request an order for Benadryl to be given as a sedative, or discuss possible reason for agitation with the child's mother. It's A. You want to check the medical record to note the time of the last breathing treatment. Remember, bronchodilators such as rescue inhalers, known as albuterol, can cause jitteriness, agitation, and shaking. The key to the stem in here is the shaking. The vital signs are relatively okay. They're not terrible. So you want to kind of look at other reasons. What is the priority nursing goal when caring for a patient with cystic fibrosis? A. Preventing infection. B. Prolonging life. C. Promoting adequate nutrition. Or D. Optimizing development. Preventing infection. Most complications from cystic fibrosis deals with chronic scarring of the lungs. So infections over time can cause that. You want to decrease infections overall.